We'll keep it on that one for a sec. Hello and welcome to Hernia Patient Support Group. My name is Jackie and I'm one of the admins of the group, and I'm delighted tonight to be able to be joined by Professor Marc Miserez from Belgium, who is here to talk to us about hernia in children. Hello, Marc, and welcome to our webinar here.
Hi, Jackie.
This
Hi, Alexi.
chat will be recorded and it will be available on YouTube later tonight. So hernia in children, I think as a parent, when there's something wrong with your child and you know that they may need surgery or anything, it can be a really worrying time for patients, for parents especially, to understand and to get through the hernia journey. So I think if we start, Marc, do you want to explain to us what is a hernia?
Yeah, indeed. That's what it is all about at the start, Jackie. As you can see here, you can see the muscles of the abdominal wall. The tummy is, let's say, more or less a balloon surrounded by muscles, as you can see here in red. And if the muscles do not come together well, then you can see some weakness, as you can see here, with an expansion of the peritoneum, which is let's say the layer surrounding the balloon of the bowels, and then bowels pop out and can get out, can get in. So most parents will then recognize a kind of a lump, a reducible lump going up and down. That's basically a hernia.
Okay. And what are the most common hernias that children experience?
The most common, I have taken out the two really most common in babies, infants, and young children, which is in one hand the inguinal hernia, as you can see here in the top, in a boy, where scrotal swelling or inguinal swelling, so inguinal swelling and scrotal swelling, they can go together, as you see in this child. And then on the other hand, it's the umbilical hernia, as you can see here in this one, with a belly button, which instead of going in is really popping out due to the reducible and recurrent swelling around the umbilicus.
Okay, so I know you've got a slide, haven't you, there, that's showing us what the hernia looks like from inside the abdomen.
Yes, indeed, because sometimes it's difficult for patients and parents
To
specifically
visual, yeah.
to visualize, indeed. So what did I do in this slides? I show here the surgeon who is doing a laparoscopy, which means insufflating gas in this sac, in this belly button, and then looking at a screen with this endoscope, with this camera, which is basically laparoscopy, looking into the abdominal cavity. And then if you look at the umbilicus, you can see here a strong abdominal wall with here at the level of the umbilicus, a kind of weakness where yeah, as you can see, a bowel can pop out. And here on the top, you can see the right groin of a male patient. So looking from the belly button again to the right groin, and the right groin where the vas deferens here and the spermatic vessels to the testicle, they run away. And here you see this is very nicely closed in the right groin. And then on the other side here, you can see that there is an opening where again bowel can pop in and pop out. And so this is basically on the top an inguinal hernia and on the bottom an umbilical hernia.
So why is it, Mark, that some babies are born with these hernias? Because we know why adults can get them, but for babies, why are they born?
Yeah, indeed. Why are some babies born with hernias? Here on the left side, you see again this belly button. So here is the belly button. Here is a kind of an expansion of the belly button going to the scrotum, while the testicle, you see the testicle is quite high here at month 3. And during month 7 to 9 of the pregnancy, you see the testicle going down in the scrotum. And together with the testicle going down in the scrotum, you see this kind of expansion here of the peritoneum, of this balloon going out with a kind of an expansion up to the testicle. And normally at time of full pregnancy, so at 9 months, you see that this is nicely closed. So nature has made a kind of a closure here. This is the belly button, nicely, completely interrupted from a little bit of fluid, which is completely normal around the testicle. So this is what happens during fetal development in the groin. And this here on the right side is what happens during fetal development at the umbilicus. Because at the umbilicus, all these structures here go to the placenta, coming from the bladder, coming from the bladder, from the intestines. So a lot of things, a lot of structures cross through. And this is, of course, why when the baby is born, there is a kind of umbilical cord that we have to clamp, because otherwise we would have some bleeding and some loss of other tissue, of other fluids. So this clamping is done, and this is a weakness. This weakness which I'm showing now is exactly this weakness here, where the muscles are not, let's say, connected. But again, this is what happens when the baby is born at, let's say, 9 months. However, why are then some boys or some children born with hernias? Because normally, as I just said, this process has stopped after 40 weeks of pregnancy. So things are nicely closed at the umbilicus and at the inguinal region. But if the baby is born prematurely, 37, 36, or even 26 or 25 weeks, nature simply had not enough time to close these structures. So the baby is born too early, and the holes, the defects in the abdominal wall are still open. Can be at the groin, can be at the umbilicus, can be in boys, and can be in girls. And that's why, especially in premature babies, we see some infants, some babies born with inguinal hernias or with umbilical hernias. Yeah.
So we know that this is why babies are born with hernia, but what about if the child develops the hernia, maybe say if they're 1, 2 years old, are they born with this weakness and then it develops?
Yeah. Well, here again, you can just before answering your question, here again you can see an inguinal hernia. Maybe the slide on the right side is the best one, because you can see here the belly button. You see here this connection, which is here closed. Here on the left side is closed, and so here the connection has left open. And if the connection is quite small, it is just fluid running through here in blue. We call this a kind of a hydrocele. So no bowel can get through because the channel is simply too small. If the channel is a bit enlarged, a bowel can go through from the belly button up down to the scrotum. So that's an inguinal or a scrotal hernia. And coming back to your question, maybe I will first, coming back to your question, I had another one. No, it will come later. These are some risk factors, Jackie. I told you already one, the premature birth. Boys clearly have a higher risk for inguinal hernia. In umbilical hernia, we see more of them in children from African race. We don't know exactly why, but that's the case. Patients who have a family history with hernias, probably due to some collagen disease, some connective tissue disease, which is weaker in some families, have a higher incidence of hernia. And then lastly, we see also more hernias, more groin hernias in boys with undescended testicle. If the testicle is not rightly down in the scrotum, we see more association with the hernia. Patients with cystic fibrosis have a higher likelihood for hernias, both umbilical and inguinal, which holds also true for patients with Down syndrome or trisomy 21. So these are some risk factors in children where you can expect the higher likelihood of a hernia coming up.
Okay. So you have a short video that you want to play for us. Do you want to just show us the video if it will play?
Well, yeah, the video, I left out the video for the moment. I can show it in the end if you want.
No, that's fine. That's fine.
Because the video shows the anatomy in an adult, and I thought maybe that will, let's say, maybe confuse parents, because in children we most of the time see one type of hernia, and the type of hernia, as you see here, is, well, we call this as medical specialists an indirect inguinal hernia. That's not so important for the parents to know. It's the bowel popping out up to the scrotum. What I think is more important to know is, as you also asked to me before, is how can parents now know that pain or discomfort, if they have the baby with them, is really due to the hernia.
Yeah.
This is why, Jackie, I didn't show the video, but I showed here the video, the picture of a few moments ago, but turned around as if the baby is laying down with the head
Right.
a bit tilted. Because this is what we try to learn to parents. If we think that the hernia is causing discomfort or pain to the patient, we learn the parents how to very, very gently move over the top of the scrotum and push very gently this bowel back into the abdominal cavity. We learn it mostly in the neonatology department or in the pediatrics departments. And we call this, of course, as you know, we call this a hernia reduction. The lump, the swelling, the bowel is pushed back in the cavity. The hernia is still there, but the bowel which herniates through it is going back in the abdominal cavity. And of course, if the pain or the discomfort gets better, the baby drinks again better, is not crying, is not unhappy, after reduction, then the hernia is very likely the cause of the pain. Now, related to this reduction, which is normally very easy and not painful for the patient, if the parents cannot reduce this hernia, the hernia can be stuck. And we call this, the same as in adults, an incarceration. I will come back to that in a few moments. But then, of course, if we think about an incarceration, and I will highlight the possible symptoms of an incarceration in a few moments, then an urgent surgical advice is warranted, whether it's in the night, whether it's in the weekend.
Yeah, so if parents are at all worried about the baby, then they must seek medical advice. It doesn't matter what time of day or night. It's important that if you're worried at all about your baby or your child, you speak to somebody.
That's right.
Because I think parents know their children better than anybody, really, don't they? So they have this sixth sense as a parent that you know when something's not quite right.
I completely agree. They know their child as the best, and indeed, if something is abnormal, they can try to reduce this hernia if it's a groin hernia. But if that doesn't work, or it's difficult, indeed, they should look for advice of their GP, pediatrician, or even the emergency department. Yeah.
So we know that incarceration. What are the other symptoms for parents to look out for?
Yeah. So here again, I showed a kind of a drawing of an incarceration, and if you don't know exactly what it means, you see here is again this opening. The belly, the bowel went out, but the bowel is stuck because the opening is quite narrow and the bowel can't go back inside. If that's the case, this is incarceration. But if that's the case, this bowel is at risk for getting not enough blood supply. And then we move from an incarceration to a strangulation. And the strangulation means, as you can see here, the bowel gets blue, the bowel gets black, and the bowel will die. And if the bowel dies, this is really an emergency because the bowel can perforate. So most of the time from the start of incarceration, we always have learned as doctors that we have about 6 hours between the beginning of incarceration and really an strangulation and all possible consequences. And here I show again from inside. I showed the laparoscopy before, and here again I show the laparoscopy on the top for an inguinal hernia in a boy, and on the bottom an inguinal hernia in a female patient. Here, let's first look at the right side. Here, if we look from the umbilicus to the right groin, you clearly can see the opening. And here you see in this opening a bowel is stuck. The bowel is incarcerated. Same in a girl. Here you can see the opening where here it was not a bowel which was incarcerated, but an ovary. Because here you see the uterus. Here you see the uterus. In a baby girl, we can have the bowel which is incarcerated, but we can have even more frequently in young babies, we can have an ovary or a fallopian tube which is incarcerated. And of course, we have only 2 of them, or girls have only 2 of them. So it's really important to recognize this and to try to reduce an incarcerated hernia in a girl, because the ovary or the fallopian tube, as you can see in this part of the slide, can be incarcerated. And we also know, and that's the tricky thing about seeing patients or young children with a hernia, the younger the child, the more premature the child, the higher the risk for incarceration. So incarceration risk goes down with increasing age.
So do
I don't know.
babies,
Okay. Sorry.
do babies exhibit the same symptoms as an adult with incarceration? The pain, the fever, the vomiting, the redness around the hernia sac?
That's completely correct. Only one thing: if they're very young, they can't say it.
No.
And indeed, that's the point. So you will have to rely on some indirect signs, as you just said rightly. The hernia cannot be reduced, but the baby will have acute pain and discomfort. So those 2 signs, a mass which normally goes up and down, which cannot be reduced, and your child is really in discomfort, this should you alert to look for an emergency contact at an emergency department. Because vomiting can be associated, abdominal distension can be associated. If the bowel really is strangulated, fever and some skin erythema, but then of course we are already in a kind of an advanced stage. So indeed, as you just said, the message is an unreducible hernia, a lump in the umbilicus, a lump in the groin, and your child is in discomfort. This must be the sign of looking for an emergency advice. What can be other signs to seek medical advice outside of the emergency setting? When the hernia gets more and more difficult to be reduced, then it doesn't make sense to wait, and you should consult your surgeon. If your baby or your child really has regular pain or discomfort where you think it's related to the hernia, don't wait and consult a medical doctor. And last but not least, of course, if the hernia gets bigger and bigger, it's of course it makes no sense to wait. Then again, you will contact your doctor. The last 3 of them, of course, are not really emergencies. You have time. You have a few days. You have a few weeks. And what is very important, even in the setting of an incarceration, Jackie, it's never dangerous or forbidden for parents to pick their baby up, to pick up their child, to hold him or her in their hands. You will not damage anything. You will not damage any ovary or any bowel by just picking up your child and trying to reconfort it. So that's a very important message, I believe.
Yeah. What about, if the baby's like toddling and they've got a hernia that hasn't been repaired, we know what babies and children are like. They love going off to explore. Parents may be worried that the hernia could be made bigger. They could make the hernia bigger. They could cause more pain to the child. Is there anything a baby or a child shouldn't do when they have the hernia? They just get on with life as normal.
Yeah. Well, first of all, it's very difficult to say to a young child, you should not do or you cannot do this. In an older child, it makes more sense. What we sometimes say to an older child who has a hernia and, for instance, is waiting for surgery is try to avoid all actions which increase pressure in your abdomen. And of course, that's not always easy, but no. I just give some examples from adults which can be mimicked also in children: constipation, hard pushing, sneezing, coughing, doing a lot of exercise where you have to push or to increase the pressure in your abdomen, because then, of course, if you increase the pressure in your abdomen, the chances of the bowel popping out in that hole are bigger. But of course, that's not always easy. And again, more importantly than that is the discomfort or the pain of the patient. Because if the hernia pops in and out, and it doesn't disturb the patient or the child, that's not too bad. I mean, they will go to school, they will play around. That's all fine as long as they have no pain and the swelling is supple and soft. There is no issue, and they can just go ahead.
That's great. So I think that's the worry. I mean, especially with babies, they can get themselves into all sorts of particular shapes and situations, can't they? So,
Right.
yeah, I'm sure they do have their own way of letting us know when something's bothering them. So, what is the treatment for hernias, Mark?
Yeah. Well, indeed, what we are. This is a surgical society, the European Hernia Society. So, indeed, treatment of a hernia is surgery. Without surgery, most of the hernias, I will come back to that in a second, but most of the hernias will not go back, will not disappear. Now, first of all, mesh is not needed. Why is it not needed? Because a repair without a mesh simply does the job. So generally, we don't use any mesh in any patient, not for umbilical, not for inguinal hernia. Let me first talk about inguinal hernia, as you can see here on the left side. So what do we basically need to do as surgeons? We need to close this hole. We need to close this up. We need to stitch it up so that the bowel from the belly button, from the tummy here, cannot get into the scrotum anymore, as you can see here in a boy. We can do this in two ways, Jackie. We can do this with the keyhole operation, so coming from the umbilicus, and you see some images over here. So here you see a left-sided hernia with the opening very clearly, and so the surgeon is using a suture, using a thread, and doing some actions to move from an opened hole here on this side to a completely closed here down on the right side. Of course, we should not damage the structures in the neighborhood, which is the vessels to the testicle and the vas to the testicle where the sperm is coming through. So this, of course, should be left unharmed. But for the rest, we try to close this extension of the peritoneum with the suture. If we do it without a keyhole operation, we come from the groin, we make a small scar in the groin, and essentially we do exactly the same. We will close it up, as you can see here. Here are the vessels running to the testicle and the vas deferens. So these structures, we isolate as a surgeon this extension of the sac, this one, which is coming from the abdominal cavity, and we simply place also a suture here to make sure that no bowel can get into this part which went to the scrotum. Now, importantly, in inguinal hernia in a child, we can do it without a mesh, and even more, we can do it with simply closing this peritoneum. So we don't need to approximate muscles. And this is a very important one. So the muscles here of your belly button, you don't need to close muscles on top of this peritoneum as you need to do in an umbilical hernia. So here again, in an umbilical hernia, we don't need mesh, but there is one big difference. We will use sutures to close up, but here we will close up the muscles. So we will really close up the abdominal wall to bring the muscles from the top and the bottom back to each other, which is not the case in an indirect inguinal hernia in a child. So that's basically a difference. But so we don't need mesh, we don't need any foreign material when closing up a hernia, whether umbilical or inguinal, in a child.
So is there a higher risk of recurrence then because you're not using mesh, or is that different because it's a young baby or child?
Yeah, no, that's right. I will show some data in a second. I don't know. No, it's a slide a bit further coming up. The risk for a recurrence is generally only 1%. And this is without a mesh. This is both for umbilical and inguinal hernia. It's around 1% or even a bit less in the umbilical. But so with a mesh, we cannot make it better. Moreover, the child still needs to grow. The mesh will not follow that growth. So I think in those children, a mesh can even be more giving some potential complications because the mesh will stay in place and the baby will, or the child will grow. So mesh is not needed. Of course, yes and no, and always and never do not exist in surgery. We will have some patients where 2 or 3 or a fourth hernia is coming up, or we have some specific types which are very rare, and there we might use a mesh. But this is, I think, outside of the scope of this basic information we want to give to parents.
Yeah. So, is there a minimum age when it's best to repair a hernia?
Yeah. Well, that's a good one. That's a very good one. And I think we have to make a clear distinction here in premature babies. The older children will come up in the next slide, but premature babies are very special because they are very fragile. They have risks if you operate them too early. They have risks for respiratory complications, some cardiac complications. The risk for a recurrence is higher because technically the structures that we need to operate are very fragile. And you have two options. You have two schools. In a premature baby, when the child is on NICU, most people, and there is a very nice paper and a very nice publication, research paper from 2024 from the States, most people now tend to operate after discharge of the NICU, which means the baby goes home with a hernia. The parents know what to do. They know the alarm signs. And when the baby is more than about 55 weeks post-menstrual age, so this means the age during the pregnancy and the current age of the baby all taken together, when that is more than 55 weeks, then surgeons tend to operate in better circumstances than before discharge. So it can be done if the hernia is very big and the child seems to have very many complaints or discomfort, then it doesn't make sense to send the parents home and say, you have to wait some more weeks, go home. Of course, it's a matter of discussion. But if the patient, the child has not too many complaints, there are more pros to delaying the surgery. As I just said, easier surgery when you wait a bit longer, less post-operative complications with the lungs, with apnea, with stopping with breathing, than when you operate early. So there is a slight tendency to operate later, except of course if the baby has a lot of complaints, or if the patients or the parents live very far away or are very anxious. You could say, okay, but if you wait for a longer time, then much more babies will come in with incarceration. Well, theoretically, this is the case. You're completely right. But if we have to weigh those risks of incarceration versus the risks of the early surgery, then the late surgery is winning. And this is some very recent research. So I think you should discuss this with your neonatologist and with your surgeon. But there is a slight tendency to operate a bit later. If the baby is not premature, then it's very clear the baby or the child will come to the surgeon or the pediatric surgeon with a symptomatic hernia at a later age. And then the surgeon will most of the time plan surgery, because it's very unlikely that the hernia will disappear spontaneously. So when the child comes at 2 or 3 or 5 years old, the surgery will be scheduled. This is slightly different in the umbilical, because the umbilicus is a very special structure, and it really has the tendency to close up in the first 4, some people say even 6 years after birth. So if we see a child with a small umbilical hernia and the parents say, wow, not too much complaints, he or she can do everything, there is a swelling and it pops up, but it doesn't hurt, it doesn't give complaints, we generally tend to wait till 4 to 6 years, because in contrary to the inguinal hernia, in the umbilical hernia, it's very likely that the opening in the muscles will close spontaneously. And then, of course, you have avoided surgery. So in a summary, in umbilical in an older child, we tend to wait. In inguinal in an older child, we tend to operate.
Okay. And who should repair the hernia in children? Is it going to be like a hernia surgeon or a pediatrician?
Yeah. Well, it will not be a pediatrician, because the pediatrician is not a surgeon. It will be a surgeon anyhow. It needs to be a surgeon with expertise. And this depends a little bit from country to country. Of course, if we talk about surgery in a neonate or in a preemie, that's the job of the pediatric surgeon. That's clear. The pediatric surgeon has the expertise of operating, let's say, all diseases in the child up to 16 years old. However, in some countries, an older child with an umbilical hernia or an inguinal hernia will safely and securely be treated by the general surgeon. So also general surgeons have been trained in many countries to do the surgery. So it really depends on, you can ask the advice, of course, of your GP or your pediatrician, but you should go to the surgeon and you should see that he or she has the experience. You have a good feeling. On one hand, you need to have trust in this person, but this person also needs to show you that he or she covers the matter, that he or she has done it before, that you ask about him or her about the results, and that they can deal with it. So these are the two groups of surgeons that generally will take care of an inguinal or an umbilical hernia in the child.
Yeah, I think that's one of the things that we always recommend to patients, no matter what the hernia or who the patient is, that you must question your surgeon about their experience and what are the results they're getting from surgery, what are the recurrence rates. And I think that's even more important with our tiny babies and children.
I agree.
So Mark, how do babies and children, how do they cope with surgery?
Well, most of the time, this goes quite well. So the risk of complications is low, and this surgery is generally very, very well tolerated, both the surgery and the anesthesia. However, and so that's why, as you can see here in the slide, in the lower part, most of the children, when they're not premature, can safely be operated in a daycare setting. So that's very reconforting for the parents. They go with their child up to theater. The child comes back after 45 minutes or after 1 hour, and they will go home the same day. The only exception is generally patients who are less than these 50 weeks of post-menstrual age. So again, post-menstrual age means the duration of the pregnancy and the age of the baby. If that's less than 50 weeks, if you count all of this together, the risk for respiratory complications, apnea, stopping with breathing, bradycardia, which means a too slow heart rate, the risk is higher. And surgeons, pediatricians, and anesthesiologists, they want to keep the baby under control for at least 24 hours. So in those circumstances, it will be very rare that patients will go home the same day. And so surgeons and anesthetists should warn the parents on beforehand when they come to the outpatient clinic, should explain them, or to the consultation outpatient clinic, should tell them that here your child will most likely stay 1 night, sometimes 2, but most of the time 1 night, because then we can have a better view on them. And if there would be trouble concerning breathing or heart rate, we can easily and correctly deal with it.
I think from my experience, when my daughter had to go down for surgery, it's harder for the parents than it was for the child going through it. That waiting, the waiting around was horrendous for the parents. But
you have to you have to give your child away for a certain time, and of course, yeah, that's the painful thing.
Yeah, we have to trust that you're the right person and have complete trust in you to do the surgery. So after the surgery, how can we help the babies to recover?
Yeah. Well, a very important one, and I made a specific slide on that, is sufficient pain control. Generally, again, the patients, the children, don't have too much pain. But everything, of course, is related to dealing with that pain and sometimes even anticipating on the pain. Apart from that, the same story holds as I told you during the incarceration. Even if the child has been operated recently, a few hours ago, yesterday, 2 days ago, again, it's not dangerous at all. It's not forbidden at all to pick up your child and to hold him or her in your hands, to give him or her some warmth. Of course, try to avoid to touch the wound sites, which is logical, but you can take your baby, the baby or the child can walk around if the pain is not too extensive. Drinking can be started quite soon after surgery, a few hours. And again, walking around is not forbidden. Most of the time, pain is a very good alarm sign. If the patient really has too much pain, he or she will stay in bed. But if the pain can be dealt with, then you just let your child get out of the bed and walk around. So sometimes nature is a very good controller, him or herself, of what can be done or should be done.
Yeah, I mean, we always say to patients, don't we, that they're better off getting up out of bed and walking around as soon as possible to aid the recovery and to drink as much fluids as they can to keep the bowels moving.
Yeah.
The last thing you want after surgery is for the baby to become constipated.
Yeah, I completely agree. And so this is also true already early through recovery for a young child.
So, do you want to move on to your next slide?
Yeah, well, indeed. Here, this is what I took over from what we are doing. So it's in Dutch, but of course it's easily explainable. Most of the time we combine paracetamol, which is let's say the most innocent but very powerful painkiller, and we combine it with antiphlogistics. And most of the time this is ibuprofen. And so when babies go home in our daycare center, as you can see here, for paracetamol, we say max every 6 hours. For ibuprofen, we say max 3 times a day, so every 8 hours. And so the amount of paracetamol they can take really depends on their body weight.
On the size of the baby.
Indeed. And so surgeon and anesthetist, let's say, will tick the box, so that parents clearly know we can go for a suppository, we can go for some syrup, we can go for an oral administration of paracetamol or ibuprofen. And both of them in combination generally do the job for a few days. And that's all what they need. After a few days, most children are again up and running with only this combination of drugs. So you really don't need, in generally speaking, you don't need up to go morphine or other strong painkillers. These two can generally do the job.
Yeah, I think children bounce back a lot quicker, don't they, from any illness or surgeries than what us as adults do. They're a lot more resilient than what we are.
Very true.
So, like we just said, keep up top of the painkillers, plenty of fluids, walk around within the limits that the child or the baby can do. What about wound care? Keep that clean. Do you tend to stitch it or glue the wound, the incision?
Yeah. Sorry, go ahead.
Go on, sorry, I was just going to say, can the baby have a bath or a shower?
So indeed, we tend to close the wound with glue or with resorbable sutures. What is the most important for the parents and of course for the child is that no sutures or anything needs to be removed. So we don't need to go with them with any knives or any things to remove sutures. That doesn't make sense. This is not done anymore. So generally speaking, sufficient pain control, early mobilization, early resumption of drinking and eating, as I already said, is common sense. Keep wounds clean for the first 10 days. After 10 days, the dressing can simply be removed, and so again, no stitches need to be removed. Most of the time, anywhere after being operated, whether in a daycare center or not, you will get, or the parents will get from the nurses some extra waterproof dressings to put on the wound, and with those the child safely can shower from the next day. And what we normally tend to do in adults is we still try to limit some activities. However, the evidence is not very high to do that, but we've always learned to do this. In children, however, it simply does not seem to make sense, because even if you say keep quiet for 2 weeks, we don't know whether it makes sense, whether it decreases the chances for problems or for a recurrence. Moreover, if the child has no pain anymore, yeah, they're up and running again, and they will play with their friends and brothers and sisters. So generally we say no limitation of activities. Pain will control it, and pain will be the general marker for them to be still a bit quiet and passive, but when the pain is gone, they can just move on.
Yeah, I think it's important, isn't it, with the little babies and children to get back into the routine again as soon as possible.
Yeah, right.
So we've talked about the procedures. What are the recurrence rates then? We touched briefly earlier on. So what's the likelihood that once they've been through this, then the hernia may come back?
Yeah, indeed, as you just said, we already touched it briefly. I just made a slide here to give you some numbers, and of course, numbers are always there to be criticized. But I think these are numbers where you can confront your surgeon with and say, okay, do these numbers make sense? And what do you think of these numbers? Superficial site infection, whether it's laparoscopy or even an open incision in the groin, the risk is very small, less than 1 in 100. Recurrence, it depends a bit. The recurrence rate in premature babies, when the peritoneum, when the structures are very fragile, the recurrence rates are higher. That's clear. But still a recurrence of 1 to 2 or even 3-4%. But it should not be higher. If your recurrence rate is higher, I think you as a surgeon should look back, sit back, and see how you can do better. Damage to the vas deferens. It happens, especially in premature babies when the structures are again very, very tiny. It happens, but it's very rare, 0.1, 0.05%. And then even more rare is the testicle moving up or not being well positioned low in the scrotum in a child, or going to some atrophy, which means that the testicle volume is going down. These are rare complications, less than 0.05, 0.1, 0.01%. And in umbilical, we don't see too much of that. We don't see too much superficial side infections. So there, if you see a problem, it's a recurrence, and the risk for a recurrence, even in a child with an umbilical hernia, is lower than in an inguinal hernia. So we estimate it around to 0.5%. So 5 in 1,000, which is indeed very, very low. But these are numbers where I think most surgeons will agree with.
So we've touched on that. How do you explain to a baby or a child, well, not to a baby, obviously, to a child that they need an operation? Because that's something that they don't always understand, is it? And it can be a frightening experience for them.
I completely agree. And of course, here we use a little bit what we can of the media. We have some books. We have some videos, and here you see some of our hospital in Leuven, where we have Oscar as the patient in the operation room, and we have some specific information brochures. And you can see here it's in Dutch, but we add in this book, which is a drawing book for patients. We add some special notes for surgeons. But I looked for this lecture. I looked a little bit also on the internet, and from Bristol in the UK. I found a very nice video, which I think is very nicely done. I had a look at it a few days ago. It's a patient, a child guide, or even a family guide to anesthetics, because at that moment when you come in the hospital, many things are coming up to you in a kind of I'm not saying aggressive, but important way, and it can be very frightening, especially to young children. And I found this video, which is freely available on the internet, quite interesting. So I would say, if parents want to touch with their children before going down to the hospital, and they want to have a look at home to what will it all be about and how would it look like, then I can really advise this to look at this guide to anesthetics, which is again available on YouTube when you look for the Bristol Children's Hospital.
Right, we shall have to have a look for that. Thank you.
So this makes me coming back to the UK, Jackie, where you are for the moment.
Yes, we are. I'll have a look at that. We did one of our chats not long since with the anaesthetic about anaesthesia, and the anaesthetist talked us through the process from the minute you go to the hospital to having your surgery and being discharged. So yeah, I guess it's pretty much the same, that things do move along quite quickly once you've been admitted to hospital. So I think if we can have one for children, that's brilliant.
That's it. And again, I mean, the surgery, of course, is important, but the child or the parents don't know what we're doing inside. But of course, making that child going asleep in an elegant way, waking up again in an elegant way, no distress, all quiet, the nurses anticipating on that, the anesthetists anticipating on that, the doctors anticipating on that, that makes it, let's say, a more positive adventure for children and parents. And so that's why I think we shouldn't put some more stress on coming in, the different steps in the hospital, the carousel that they have to take, the going asleep and the waking up. And so for this, the video is I think really well done.
We shall have a look at that. I don't know if anybody has any questions, but what would you recommend, Mark? Would you recommend an open or a minimally invasive procedure for the children?
Well, I'm a laparoscopic guy. I do my Hirschsprung patients laparoscopically. I do my anorectal malformations laparoscopically. So I like laparoscopy both in children and adults because, as you know, I operate both of them. For the inguinal hernia, to be honest, I'm not convinced of the advantages of the laparoscopy. So I use a laparoscopy sometimes to get into the belly button, through the belly button and have a look around to check for both sides, to check which type of hernia it is. But in repairing, I still rely mostly on a classical open repair with a small inguinal incision, which will be covered in the groin, which nobody will see. On the other hand, for instance, if it's a recurrent hernia, then I will move to laparoscopy because you want to avoid going through some scar tissue where a surgeon has already been before. So my general tendency is primary hernia, open repair, recurrent hernia, laparoscopy.
Do you have any advice then for parents? Because I know in the Facebook group we get a lot of people struggling with the gas pain, because you have to use gas, don't you, to inflate the insides of the body when you're using laparoscopic procedure and robotic procedure. And for babies, it's a bit like colic, isn't it?
Yes, I think it's very important to think about your pressure, your insufflation pressure in the abdominal cavity. So you have to adapt that. Where we use a pressure of 12 to 15 millimeter of mercury in an adult, we will do less in a child. So we will use just the insufflation pressure, which is convenient for us to work on one hand, and secondly, of course, where the anesthetist feels comfortable with. So because it's a joint venture. Us and the anesthetist and the nurses all taking care of the child together. And so we try to minimize the insufflation pressure of CO2 to a minimum so that it's still convenient to work and, let's say, of minimal risk for the patient. And generally, there were a lot of concerns when you started with laparoscopy 25 years ago or 30 years ago. Now working with CO2, even in the youngest child, but adapting your insufflation pressure is really a safe act.
So we've talked about babies and the children. How do you reassure the parents?
Yeah. Reassuring the parents, it starts from opening the door and seeing them. Because if you can reassure the child, you can mostly easily reassure also the patient, the parent. So I try to, well, of course you will give all technical information to the parents, but for the rest, I try to stress on that child that is there. And I want to make sure that me as a surgeon and the child, we are brothers in arms for this event. We will take care of it. So I take many children, I take them on my knees. When I examine them, when I have examined them. So I really make them part of the deal. And then, of course, if you do that, the parents also feel happy. So
yes.
I do it very often indirectly. I give them the basic information they need on what will happen on open versus laparoscopy, the possible complications, but the child is in the center. And this is also like that during the outpatient clinic. And of course, also when he or she is coming in theater, yeah, the child is going in the picture, in the middle of the picture, and has all my attention. And this I think is one of the most important steps to make the parents also feel as this is going to work, and then everybody's happy most of the time.
I think that's it, isn't it? It's a case. I mean, I know how I felt when my daughter needed surgery, and we see it sometimes with parents, and they're getting themselves so anxious that then you pass it over to the babies and the children, and we want to try and avoid that by reassuring mum and dad that everything's fine and you're going to take care of everything, and the baby and the child's going to be all right and going to be happy and healthy, back to normal within a few days.
Fully agree.
I don't know if anybody else has any questions. If you want to use the chat box, please do, or let me know. I think you've actually covered everything that we really wanted to discuss tonight. It's been a really interesting discussion. And I know that this is going to be available later on YouTube, and especially for World Patient Safety Day, which is tomorrow, and the focus being on babies and children. I think this was a very appropriately timed discussion that we had, Mark.
Great timing.
Very good timing. They must have known. So, okay. So I think that with that, I think we've covered everything we needed to. So thank you ever so much, Mark, for your time tonight. And thank you, everybody, for attending. And hope to see you soon.
Yeah, thanks, Alexis. Thanks, Jackie.
Oh, wait a second. Wait a minute. Alex is we've got a question.
Okay. All right.
Do you ever take a look at the other side when you're performing an inguinal hernia?
Very good question. Yeah. Yes, I take a look at the other side clinically. So I check whether there is a swelling indeed. That's number one. If there is some doubt, some the nurses or the parents say there is some swelling, you can check it with an ultrasound, which is a non-invasive investigation. And if I'm in doubt, even if I'm not doing a laparoscopic repair for the primary hernias, if I'm in doubt, I will do a laparoscopy. So I will look inside, for instance, in a premature baby where there is some doubt about the other side. I will have a look. And then, of course, the big question is, if you look at the other side and you see a small opening, will this become a hernia or not? Well, there are some rules and some technical aspects on the size of the opening, on whether that might become a hernia. But I tend, especially in preemies, I'm not a big fan of prophylactic surgery, because we know, and this has been a debate over the last 50 years, and I think the debate is still going on. And when I retire, the debate will still be going on. I'm not a big fan of prophylactic surgery in a premature baby, because we don't know really how many, if there is a small opening hole, how many of these small open holes on the non-symptomatic side will ever become a hernia. So there I prefer to have a look. If there is a hernia or a swelling, I go on with it. But if there is no swelling and only a minimal hole, I tend to wait. And I must say, some patients come back at an older age, but many of them, we never see them back. They might go to St. Elsewhere, of course, but I think that there is no common ground, or no, let's say, no general agreement within pediatric surgeons to systematically do a laparoscopy and operate when there is only a tiny open hole. That debate has not been solved, so there I prefer to stay on the conservative side.
Very good.
Good question.
And what about, I know you said that the inguinal hernia was coming from the umbilical from the muscle. Was it dropping? Do you repair an umbilical hernia if there's an inguinal hernia?
So I don't know if I got your question. So, but indeed, in an inguinal hernia, it's sufficient to close the extension of the peritoneum, of this balloon of the belly button, but we don't close muscles. We don't make it firm muscle to muscle. which we still do in an umbilical. There we will close muscle to muscle, but in the groin we cannot. Why we cannot do this in the groin of a boy? Because the structures to the testicle, the blood vessels, the vas have to run there. So you cannot completely close the muscle, because then you will tighten the important structures for the fertility. So you need to leave it open a little bit. And we have learned in history that just closing the peritoneum in inguinal hernia in a boy and in a girl makes the job done properly on the long term. So that's why there is a difference between inguinal on one side and umbilical on the other side. Was that a question or not really?
I think that does. I think so. Thank you. So unless we have anything else, anybody else, any questions? I think we'll let Marc get on with his evening. And thank you very much, Marc, and we will send you a copy of this shortly.
Super.
Thank you, everybody, for attending tonight. This has been a really good discussion. So thank you. And we've got to thank you there, Marc, for your time and for all your expertise.
Pleasure for me, and thanks to EHS, and thanks to you for moderating so well. Thank you, everybody.
Thank you. Have a good evening, everybody. Bye-bye.
Bye-bye.